afternoon. I'm Robert Stiles. I am the program director for the Kansas Disaster Outreach Program, along with KU Telehealth Rocks. And we're really excited to have everyone today to the next in our series of ongoing echo telemetry series, which we'll be looking at the sort of next step after many of you were in our psychological first aid, sort of immediate response to disasters or other traumas. And this will sort of look at the next step. And we're really pleased to have everyone who's been in previous echoes with us, whether the psychological first aid or behavior or complex medical conditions, or many of the echoes that we offer over the years, as well as all of you that are new, and really excited to have all of you learning about psychological recovery along with us. So I wanted to hand off to one of the members of our team who will introduce the rest of the team, Dr. Melissa Maris. Welcome, and glad to have you start us out on this series.
Fantastic. Thank you, Robert, and good afternoon, everyone. My name is Melissa Maris, and I'm a clinical community psychologist. I'm based out of Columbia, Missouri, but do work with school districts across the states of Missouri and Kansas, and I'm very excited to be here today to talk to you all about trauma and skills for psychological recovery in this next phase. Aaron and Joa, would you all mind unmuting yourselves and introducing yourselves so that I don't bumble it, which I surely would.
Yeah, no problem. I can go first. Hi, I'm Erin Hambrick. I am an assistant professor at the University of Missouri, Kansas City. And in both my research and clinical work, I focus on working with children and families that have experienced trauma. And so I look forward to spending these next 4 Wednesdays with you all, talking through how to help people in kind of one of these early phases post-trauma.
Okay, hi everyone, and I'll introduce myself quickly. I'm Joel Williams. I'm an assistant professor in the Department of Psychology at UMKC, and I'm also a practicing psychologist in the state of Missouri. I practice at treatment behavioral health here in Kansas City as well, where I also oversee a program for early intervention for non-fatal shooting victims, and a lot of my work focuses on early intervention for trauma survivors, with a particular emphasis on folks affected by violent crime and traumatic grief. And so trauma-affected families who have experienced some of those kinds of experiences. So I'm glad to be able to talk with everyone about how to best work with survivors in the aftermath of a trauma or other kind of disaster. Look forward to learning from all of you, and hopefully we can create a space where we can all learn together how to best effectively support each other and the families that we work with. So welcome. I'll turn it back over to Melissa.
Fantastic. Thanks, Joa. And also just wanted, as we start, to say thank you to the entire team. So Robert, Christy, and everyone else, there's a lot that goes on behind the scenes to put on one of these webinars. So just wanted to say thank you. And thank you, Christy, for advancing our slides. And I think we are ready for the next one. So just some quick disclosures. We don't have any financial relationships, and we are not trying to sell you anything. And then Christy, the next slide. We also are going to be sharing information with you that is based on the best evidence that we have right now and what is accepted in our professions, and are excited to hear input from you all about your experiences and what you've learned working with young people and their families. If we can go to the next one. After the session, you will be receiving a follow-up survey, and we really appreciate those of you all who completed the pre-survey. Thank you, and thank you in advance for continuing to participate in our evaluation efforts. We really appreciate that, and we use the information that you give us not just to plan and improve what we're doing here, but also to seek out additional funding so we can continue to do work like this for other friends who are invested in this topic. Also, in terms of the presentation materials, the slides and the chat log will be emailed to you after we're finished. So everything that is posted in the chat and anything that is linked on the slides, we will be sending that out. And Aaron is helping to correct our evaluation piece. We will not be emailing you after every session, but after the 4th session. So even better. If we can go to the next slide, Christy. And in terms of our general session agenda, these next 4 Wednesdays we spend with you are going to follow kind of this basic structure. We'll start with the didactic portion. So share some information with you, walk through SPR and what is covered there. We will take a break. A brief break, and then we will transition to breakout rooms so that we have some smaller group opportunities to talk through material, potentially do some role plays, and sort of work through those different scenarios. And then at the end of every session, we'll come back together and present on a specific scenario. So this is an opportunity for us all together to walk through a situation and not just get our input, but also have you all weigh in terms of your perspectives, your feedback, questions, et cetera. We'll wrap up with a little bit of Q&A, and then we will conclude. So with that, let's go ahead and transition into our content that I'm going to start you out with today. We did want to talk a little bit about what we mean when we say the word trauma. We appreciate that most or all of you all have heard about this, talked about this, are certainly working with it and seeing it in your communities and the friends you work with. But we think it's helpful as we are talking about another step in a trauma-informed response to make sure you know what we mean when we say the word trauma. So when we think about defining trauma, we rely on SAMHSA's definition and this idea of these 3 E's. So individual trauma that results from an event, so that's the first E, a series of event or set of circumstances that is experienced by that individual, so that's the second E, as physically or emotionally harmful or life-threatening, and that has lasting adverse effects, that's the third E, on functional and mental, physical, social, emotional, or spiritual well-being. So it's nice because it's easy to remember. So there's an event that an individual experiences, and then there are effects. What we, I think all probably collectively know is that it seems simple perhaps, but also is really complex. And in this kind of more straightforward definition, there are a lot of nuances that actually makes trauma really complex. So if we can go to the next slide, Christy. So when we think about events experienced by individuals and then the effects, of course, many of us are familiar with the adverse childhood experiences, studies, and that body of research. And really, as we think about these adverse events that can happen, a lot of times we are now currently thinking about these in different realms. So not just individually, but also things that are at the community or neighborhood level, as well as the environment. And when we start to look across all these different realms and think about how these different components interact, we can start to see how complex this really can be. We know going into a specific discrete trauma, so such as a natural disaster, a car crash, that different folks are bringing different things to the table in terms of the resources they have to cope and also the stressors they are experiencing. Research is also now showing that we can compare the immediate and lasting impacts of something like a car crash to the effects of prolonged stress, if it's significant enough. And so trauma really has become something we're talking a lot about, but also something that we're trying to understand more. But it really is tricky. We can go to the next slide, Christy. So when I boil it down and try to think about these 3 E's and how they connect, it's helpful for me in, kind of with all this different information to try to sort of think about these 3 different components. And think about specifically when we think through disaster response, maybe what is unique. So we have an event, an individual experiences it, and then there are these different kinds of effects. And it really is the individual experience of the event that really makes these responses different. It's why people who are very similar in a lot of ways can go through the same thing. So maybe have a very similar kind of event happen, say a natural disaster, and it can have very different effects. A lot of times in our work, we are working with friends who have already experienced something that is is difficult, and what we're looking at is the effect. And so we're starting to see and hear behaviors people are doing or saying things that are leading us to think that this might be an effect of an individual who has experienced a certain kind of event. But also when we think through natural disaster response, specifically the event component of these 3 E's comes more into focus. It is something that happens that is public, so we know that it happened. It's often shared by a number of people, and then that changes the way that individuals experience it and therefore have these different kinds of effects. And so I think it's helpful to keep these 3 E's in mind when we're trying to understand trauma. I think that in my experience and talking with people about trauma, a lot of times our brains want to put things together and make it make sense. So we talk about things like big T trauma or little t trauma, a big trauma, serious trauma, or a less significant trauma. And the reality is that when we say, does it matter? That really the response is, does it matter to the person? When we say things, this isn't that big of a deal. How do we know, right? It might be a big deal to that individual. So that's kind of the complexity there. We can go to the next slide, Christy. And certainly this was reflected in what you all said in terms of your all's experiences with working with other people and being around other people in your communities and in your neighborhoods as part of your work. So these are the results of the friends who responded to the pre-survey. So what are some of the most significant social, physical, and economic stressors faced by the children and families with whom you work? And you can see there along the bottom are the types of stressors. That percentage is the frequency that people identified that stressor. And then you can actually see the number of total respondents up along the top of the bar. So you can see based on these results that in terms of you all who are here with us today, and hopefully will continue to join us for the next 3 weeks, that you all have and that you all work with children, young people and their families who have experienced a lot of different stressors. So half indicating employment as a stressor. Digital access, 40%. We know that that is a significant stressor, particularly with COVID. Even looking at discrimination, health literacy, 22% saying parental incarceration, right? And so when we are thinking about trauma, absolutely, you all are working with the young people and their families who are absolutely affected by either specific discrete, public, shared disaster situations that may develop into trauma, and lots of other additional stressors. So when we are talking about trauma, we're kind of talking about all of it, but really wanting to keep 2 things in mind. One, a lot of different things can be considered trauma and qualify as trauma. It really is based on that individual experience. And also trauma does not, or these significant events don't always lead to negative outcomes. And that's actually part of what SPR is a part of, is that we are trying to make sure that we all have the skills so that we can intervene and provide supports and provide the right supports to different people who need those supports so that we can prevent bigger or longer term challenges from developing. If we can go to the next slide, Christy. So when we think about kind of trauma symptoms or effects, these are the kinds of things that we might expect to see or hear when we are working with someone who has been through something or is even just exhibiting these kinds of symptoms. And we expect that maybe they have experienced an event that was difficult and that maybe that we're in a trauma kind of situation. And you can see here that there are a lot of different trauma symptoms. So we can think about things that impact our mental health, our behavioral health, anxiety, depression. Certainly those are things that we hear and even see. We could also anticipate physical impacts. So things like our heart racing, having difficulty sleeping, being just physically jumpy is something that we see. We can also look at impacts on memory. So either current and ongoing challenges with short or long-term memory, or even in the way that a person remembers something that happened to them. We know that through research that memory can absolutely be impacted, and certainly the way that people are relating to other people, and the way that they are kind of functioning in different contexts. Can we go to the next slide, Christy? So when we think about trauma and these symptoms and the effects, I think it's helpful to frame it within a broader conversation of how we think about mental health and mental illness. And so we all know mental health exists on a continuum. Everyone here today has mental health and always has mental health. We all struggle with our mental health at some point or another. But of course, as clinical psychologists, the question becomes, so when is it too much? When is it too much struggle, right? And so I think it's helpful to think about this in terms of frequency, intensity, and duration, so that when we're looking at any of these behaviors or symptoms, when we're on that continuum thinking, okay, this has been a struggle, or this has been difficult for a while. How do I know if it's crossed the line into something more significant that could potentially be diagnosed or could potentially need additional support? So thinking about, whatever the symptom is, whatever the behavior or what we're hearing, whatever is happening, how often, how much, and how long. And depending on what it is, our answers will change in terms of too much, too often, or too long. And so we always want to be kind of keeping those things in mind. And of course, always keeping our eye on the impact on functioning, right? So how is being sad most days impacting a young person in terms of their relationships, in terms of their schoolwork, and things like that. And so keeping those pieces in mind, of course, kind of as I already covered, context matters a lot. And so this is part of the reason that we are so excited about PFA, about SPR, is that these interventions and this information is really geared towards helping all of the grown-ups in our communities understand these kinds of situations, because we know that you all in your local communities will be the ones who have the ongoing relationships with young people and their families, and who could really say, yeah, this was a big change, right? This was a difference. We're seeing behavior shifts and behavior changes, or this is getting worse, or this is having this impact on functioning. So kind of a way to frame it there. And if we can go to the last slide of mine, Christy, before we transition. So when we think about kind of the core principles of a trauma-informed approach, again, this is pulled from SAMHSA, with anything that we do when we're talking about trauma, that these are kind of the 6 things that we're really trying to keep in mind. First and foremost, always remembering safety. We know, and the research shows, that when we don't feel safe, our brains don't work in the same way. We don't learn things the same way. We don't retain them the same way. And so safety is really important, and that safety is defined at the individual level, and that there are a lot of different factors that shape whether or not someone feels safe or not in a different situation. That we want to be trustworthy and transparent. So we want to do what we say and say what we do. We want to follow through. That consistency and predictability is really, really important among trusted adults when these kinds of difficult situations are present. Thinking about peer support, so always how we can connect people with other people, have those relationships, and either with people who have shared those experiences or just with their friends, so that we have that social experience and that connection. Certainly collaboration and empowerment. So again, that individual experience. It's very important that we think about the individual level factors, and that every individual is different. No individual is going to react exactly the same way and have exactly the same impact from any given event. So always keeping that individual in mind. And then of course, humility and responsiveness. And so this is part of any trauma-informed, trauma-based, trauma-responsive activity, that we recognize the privilege that we bring to the table and our own baggage. We recognize our histories, particularly if it has included significant trauma, to make sure that when we're working with young people and their families, that they are the individuals at the center of the experience, that we are not centering ourselves and our experiences. Our experiences may be relevant, they may have been informative, and all of those things are important to us. But when we're talking with young people and their families, they really are the center, and we want to make sure that they are owning their stories and sharing their words and their feelings and thoughts and perspectives. So I think with that, I'm going to transition over to Erin to lead the next part of our presentation.
Yes, thank you. I was just putting something in the chat while I was trying to unmute. I just really appreciate that point that you ended with. And I think especially in the context of some of these more public, or sometimes we call them shared traumas, it can be so important as someone who wants to provide that we are paying attention to the individual and their needs, or the family and their needs, instead of filtering everything through the way that we experienced the event. So those of you who have been with us on this journey for a while, and it's really bringing my energy up. I was scanning through the participants and see familiar faces. So thank you for joining us again. But I just wanted to reorient us to not only what is skills for psychological recovery, but where does it fall in this continuum of supports post-trauma, or kind of most specifically to this series, post-disaster. So for those of you who were able to join us in the psychological first aid portion of this training, and if you couldn't make that training or didn't, please know you are completely welcome in this space. And we've all talked about needing and wanting to be intentionally inclusive of those who didn't participate in that first one. So this will be its own standalone training. But for those of you who were able to join us, we talked about how psychological first aid is something that can and should be provided to anyone that you encounter in the first hours, days, and weeks post-disaster. It's considered a primary prevention. Skills for psychological recovery was developed for kind of like weeks 2 to 6 post-disaster. However, as we kind of get deeper into this training and muddy the waters, you'll also see that you don't always have to be that strict, kind of if the shoe fits, wear it type of thing. But in general, this was developed to kind of fill this gap between what do we do immediately, and then what do we do if or once someone meets criteria for a mental health problem, or if or once someone has a need or a problem that is so strong that we are kind of using our traditional mental health supports, right? Where someone consents to treatment and receives kind of standard care. So we consider skills for psychological recovery to be what we call secondary prevention, to be something that's offered when maybe someone is feeling kind of like, all right, this happened 2 weeks ago and I am really not still feeling like myself, or there's a new problem that I'm facing right now. I'm facing insomnia for the first time. I've never had trouble sleeping, and it's 2 to 4 weeks after this disaster, and this is a problem for me, right? That's the type of space in which skills for psychological recovery can be really useful. Now, some people would also argue it's going to be very useful for anyone that you as a provider encounter. But again, it's going to be most useful for people who are able to kind of generate or talk about how there's kind of a specific problem they're facing, or a skill set that they want to develop in light of the experience that happened to them. All right, next slide, please. This slide's kind of dancing for us. Thanks. So skills for psychological recovery has some similarities to psychological first aid in that the materials, the training materials for skills for psychological recovery are free. They were developed by the National Child Traumatic Stress Network and the National Center for PTSD. So go download the manual, and we will be encouraging you to read it alongside this training. It's an evidence-informed intervention, which means that the available research literature and also experts, people who have done a lot of responding in this kind of 2 to 6 week range, their expertise and the research literature were brought together to develop this manual. This is a highly skills-focused approach. This approach is meant to identify needs that people who have experienced disaster, loss, or recent trauma have, and to help teach individuals skills to address those needs, help them learn the skills and also practice the skills with some nice built-in accountability. Generally, if you deliver SPR, you're going to be working with somebody for 3 to 5 sessions. At least that's what the literature would suggest kind of the most effective dose of SPR might be. What's a session could probably range from 15 minutes to an hour, but generally 3 to 5 focused contacts. An important caveat to that is that it is always appropriate to just have one contact with somebody if that's all you can get. So it wouldn't be contraindicated to just have one SPR contact, but the literature would suggest that 3 to 5 is going to be the most effective. All right, next slide, please. So who can deliver SPR? Well, I actually just kind of copied and pasted from the SPR manual who is kind of supposed to provide SPR, but then I want to expand on that theme a little bit today. So SPR is designed for delivery by mental health and other health workers who provide ongoing support and assistance to affected children, families, and adults as part of an organized disaster response effort. So here's kind of the deal about SPR. If you have a mental health, behavioral health, other health focused, maybe even educational focused background, learning SPR and how to deliver it might come a little more quickly to you because of that background that you have. That said, SPR is very practical and it's very skills focused. And we really feel, as do the developers of SPR, that especially Dr. Williams has a lot of connection to, that if you are a person that is going to be interacting with people during this period, you will benefit from learning SPR, and so will the people with whom you interact. So when we were looking through pretest data, we have a variety of participants here today, and we really want to express that this training is for all of you. All right, next slide, please. So I selected this image here because something that really resonates with me in terms of what is SPR and who can deliver it is that SPR perhaps most distinctly differs from counseling or kind of traditional mental health services in that SPR providers are not therapists. You're not consenting people to mental health treatment. SPR providers can really be likened to a cross between a teacher and a coach. We are teaching people skills that they can use that are relevant to the problems that they endorse. And we're helping provide support in terms of helping people meet their goals along their journey, some accountability and some really relational touches to help people along the way. Next slide, please. Where can SPR be delivered? Well, similar to PFA, we hope that people will use SPR in a variety of settings and will use good creativity really around where SPR can be delivered. Something I like about these kind of preventive interventions is that hopefully it decreases some stigma around receipt of services and also provides the ability for services to be provided in contexts that feel good to the people who are receiving the services. So I, for example, just over the past week as we've been prepping this, have really been thinking about, gosh, wouldn't it be awesome if people who were trained in SPR were located within primary care settings, right? So that when, maybe a medical doctor or a physician learns that someone has had an experience, maybe they can be immediately connected with someone who has this skill set and can help a child or a family think through specific goals. It can happen in mental health settings. I know I was sharing with our smaller group earlier that, I do treat some patients and have long-term relationships with them, but sometimes over the course of that treatment, a trauma happens to the patient. And then I kind of end up pausing the work that we're currently doing, and I start to focus on PFA and SPR and say, okay, this person's at a different phase in their life right now because of a life experience that they had. So yeah, I'm in a mental health setting, but I'm going to use this different set of skills right now. Can happen in homes, places of worship, businesses. Sometimes whole organizations have really negative things happen, workplace traumas, and businesses can be a place where SPR can be provided. So another thing, I know that Dr. Williams has been studying applications of SPR via telehealth, right? So there are a lot of potential places that we hope actually SPR would be delivered. Next slide. And before we get into kind of the first steps of SPR, I just want to spend a moment talking about, like, how do we prepare to deliver SPR? I think one thing to always keep in mind is that a strong rapport and being person-centered is always going to be extremely appropriate, and that's always going to be the foundation of what you do. So I think throughout this training, hopefully we're going to stretch a little bit and try to learn some new skills, but let's never lose sight of the fact that the relationship and the trust that hopefully you can build with an individual is going to be the foundation of the approach, right? So if you teach a skill the wrong way the first time, or forget to check in with somebody as many times as you wanted, okay, but did you have a relationship with them? Because that's probably the cornerstone. Also, when you prepare to deliver SPR, the manual is really great, but the people who developed this training suggest that alongside reading that, going through a training series like the one that we're offering right now is best practice in terms of using the skills. It's also important to kind of ensure you're part of a broader connected effort so that there isn't service duplication and so that there isn't confusion for the individual about what are you providing and how is that different than what someone else is providing to me. Because sometimes the beauty and the pain of disaster response is that lots of people start to flock and want to help, which is great. But having good connectedness with that group of helpers is key so we don't overwhelm and confuse. And also we talked again about this a lot during PFA, but it's just as relevant here that provider self-care and continued assessment of one's own readiness to do this type of work is important. There are all different types of traumas, like Dr. Maris covered. Some of them you will be better suited to helping address than others, right? So what are the types of trauma that might not be as much in your wheelhouse, that maybe you have also experienced that type of trauma, and maybe that makes you really good at helping, and maybe that makes that type of situation one that you want to step back from, right? So really thinking about who you are and how it intersects with the experience at hand. So let's move on to the next slide. And I just want to show this slide. We're about to transition into Dr. Williams' section, but this is just kind of an overview, SPR in a nutshell. We start with information gathering and prioritizing the skills that we're going to work on. And then there are a variety of skills kind of through this wheel here that that we move through, helping people problem solve related to the problems they're having, working on thought patterns, helping build social support, helping them manage trauma reactions they might have, and helping them build in positive activities to help with the recovery. So with that, I'm going to go ahead and turn it over to Dr. Williams, who's going to talk with us about information gathering and prioritizing.
Terrific. Thank you. Thank you, Erin. Thank you, Melissa. And again, thanks to all of you for being here and being part of this learning community really over the next few weeks where we can learn together. Because I think each of us, through our own lived experiences and the context of the work and the folks that we have the privilege of working with, we all bring unique perspectives to this, and I think can really learn from each other and learn how to better support the folks we work with by seeing what each of you do and what strengths each of us bring, so we can help coordinate between each other as we seek to better serve the folks that we work with. I think as Dr. Hambrick just mentioned, really SPR at its best, I think, can be an important bridge between what we can provide folks in the immediate aftermath of a trauma or disaster and later mental health services that sometimes folks will need, right? And sometimes these kinds of secondary interventions like this, while they might be enough to kind of help put folks on the trajectory towards recovery for some people, for others are going to be an important bridge to care down the road. And so these interventions play a really, really important role. And Dr. Hambrick and Dr. Maris have given you kind of an overview of SPR, how it fits in the spectrum of care along the continuum of care for trauma survivors. And we've talked a little bit about trauma and the kinds of situations where you might think about using these kinds of interventions. So let's dive right in and talk a lot about the actual skills, the application of an intervention like this. What does it involve? How do you pick what to do, and where do you go first, right? What's the very first thing that we do? So as Dr. Hambrick mentioned, there are several different skills. There are actually sort of 5 core skills, and if you include information gathering, which we're going to start with first, 6 core skills that are part of this whole intervention package that, called Skills for Psychological Recovery. And we're going to start by talking about the first skill today, information gathering and prioritizing. And then in the next few weeks, we'll talk about the remaining skills so that you really have a good sense of how each of these look in practice, know when to use them, know when to select them. One of the things that's really nice about SPR, again, is that this is each of these skills is sort of organized in the manual as a standalone module, and so you can sort of pick and choose which skills, which modules are going to be most helpful for the folks that you're working with, for the families that you're working with. But in order to select which of these skills is going to be most appropriate for helping the survivors that you're working with, the very first thing we have to do is just see what's going on, right? Get a sense of what kinds of stressors continue to be most relevant for folks, what kind of reactions continue to be most relevant for folks, where they are in their own sort of recovery from a traumatic event. And so we have to start by just gathering some basic information and figuring out what to prioritize first. So information gathering and prioritizing, regardless of anything else we do with this intervention, is going to always be the very first thing that we do. So we always want to start with this sort of core skill first, gathering information and prioritizing assistance. Before I dive into specifically talking about the steps involved in this, though, let me pause for just a second and give folks an opportunity to ask any questions that you might have about anything that we've covered first, or that we've covered up to this point. So before we actually get into the nitty-gritty details of how do you do SPR in practice, let's just take a moment to see if there are any questions or comments that folks have. And it's totally okay if not to, but if you do have questions, please feel free to jump in. Okay. If we're good, then let's jump right in and go. And just to tell you, please do jump in and ask questions. Feel free to unmute yourself and ask questions if there's something that we're talking about that you just want additional clarification on, or if you have comments or questions that you'd prefer to put in chat instead, please feel free to do that, and I'll try to monitor the chat and keep an eye out for anything that comes along there as well. But we definitely want this to be collaborative and want folks to feel comfortable and feel good and comfortable jumping in and asking questions and making comments. But let's dive in and talk a bit about information gathering and prioritizing assistance. And so if we go to the next slide here, again, as I mentioned, this is going to be the very first step that all of us are going to do as providers delivering SPR to trauma and disaster exposed youth and families, or adults or other individuals affected by trauma and disasters. And what's the goal, right? Again, this is just kind of reiterating what I've already said, but the goal here is to really identify what are the most immediate sort of practical needs and concerns for the folks that I'm working with, right? So what kind of things are going to be most important to try to address here? What are the most important stressors or the most relevant stressors related to the trauma or disaster that seem to really be directly affecting this person or this family, right? So that helps us then select what skills we can then focus on for the remaining SPR contacts, regardless of how many of those contacts we have. But it also gives us some other important information, right? Do we need to refer out to other partner agencies that have better capacity to handle certain kinds of problems or concerns that we might not have the skills or resources to be able to address. So I think by gathering information, we can not only prioritize what to do next, but we can figure out where immediate referral might be most appropriate, right? So there's kind of some important goals in just trying to figure this information out. Now, I imagine that, given the information provided in the pre-survey, many of you indicated that you have a mental health background. Many of you are licensed professionals, right, or are professionals in the mental health field. So I think a lot of this will be pretty familiar for folks who are already kind of practicing in mental health related areas. But that being said, I think there are some sort of unique special considerations for things that we want to be really targeted and asking about, particularly in the context of early intervention for trauma and disaster, because there are some unique considerations and concerns that are likely to be particularly relevant for recent trauma and disaster survivors. So let's kind of hone in a bit on what some of those concerns are and think about what kinds of immediate concerns you want to really make sure you assess when you're first sitting down with a recent trauma survivor or a recent trauma exposed family to try to get a sense of how something like SPR can be appropriate. So if we go to the next slide, I'll just kind of quickly go over some of the key areas that at least in this protocol, in this model, you want to try to really make sure you assess and ask about. And we'll spend just a little bit of time talking about this. Now, I also want to encourage folks again to sort of to jump on something that Dr. Hambrick said a little bit earlier. Please make sure you take a look at the manual. There's a screening form in the appendix section of the SPR manual that actually gives you some prompt questions that you can use to ask about each one of these areas. So I think it's a really, really helpful screening form to make sure you kind of have available just to help jog your memory and help you remember to ask about some of these areas when you're first meeting with folks. But when we try to gather information, what we generally want to try to think about, assessing is ongoing physical, concerns or physical health related concerns, right? Certainly if we're talking about a trauma or a disaster where someone may have been injured in the context of the trauma or the disaster, or if someone's family member was injured or suffered injuries in the context of a trauma or disaster, people will often have some ongoing concerns about physical health and healthcare related needs. And those needs can become very substantial stressors for people in the weeks and months after a trauma or disaster happens, right? So sometimes just making sure that you can get your healthcare needs met are going to be really, really important stressors to make sure that we as providers sort of hone in on to try to figure out how can I best help a person figure out how to meet these needs, or how can we best figure out how to get these needs met. So again, here in the coming weeks, we're going to be talking about how could SPR skills be used to try to help address, things like physical health concerns that people might endorse in the first, contact that you have with folks. Emotional difficulties, right? Now, this is one that we've already talked a little bit about. Dr. Maris sort of gave a review of different kinds of reactions that folks can have to trauma or disaster, but certainly we want to ask about that. What kinds of emotional difficulties have you experienced, or are you still experiencing right now since this event happened, right? So, trying to get a good sense of that and asking in an open-ended way what kinds of emotional difficulties folks are having can often be really useful. But that being said, it's going to be useful to ask, do you have concerns about how folks in your family are doing emotionally, right? And why do you think it's going to be important, to also just ask about how folks in your family are doing? I said that when we talked about physical health, I want to know if a person's got any, lingering physical health concerns or chronic, health-related concerns that might have been the result of trauma or disaster exposure. But I also want to know, about whether family has any ongoing concerns related to physical health, or family has any concerns about emotional difficulties. And why might we want to ask a person if they're concerned about how their family's doing too? Curious what folks think about that. When you log on, if you take a look at the manual and you kind of go through the screening form, you'll see that it'll guide you through asking about, do you have concerns about how you or a family member or a loved one is doing? And that's pretty intentional, I think. I think that's key. Why might that be the case? Yeah, so absolutely. So I noticed in chat, and so thank you for the comment here in chat, and I'll share this with others. I think this is absolutely spot on. I think it's absolutely why we ask about this, right? The family's thoughts can impact how you're doing, right? Sometimes my own ability to attend to my internal thoughts and feelings is going to be compromised if I'm really concerned about how my son or my daughter's doing, or how my parents are doing, right? If I'm really concerned and spending a lot of my emotional and cognitive energy, right, and resources trying to take care of others, even though I might have a lot of distress and difficulties managing some of what I'm experiencing myself, it's going to be hard to attend to my own self-care if I really am concerned about the people closest to me, right, and how they're doing. So I think we need to know that. We need to know what kind of stressors exist there, right? So to determine who can be there to support each other, right? And certainly it was mentioned here. Someone else in chat said trauma could have happened to the family too, right? So absolutely, we want to know who else close to you is affected, and to what degree do you continue to be really worried about their well-being, right? And acknowledge that folks are worried about the well-being of the people around them who've been affected too. So asking about emotional difficulties, and we'll talk a little bit more about that when we start talking about the managing reactions module and skills for psychological recovery here in a couple of weeks. But we also want to ask about safety. Now, what do I mean by safety? It's kind of a broad term, right? Refer to a lot of things. What do we mean by safety? Yeah. So if we're talking about, threat of intimate partner violence in the home, right? Or if we're talking about, is there a possibility of domestic violence, self-harm, right? So thinking about, has the toll of this whole experience been so much that I'm thinking about hurting myself, or even killing myself, or hurting or killing someone else, right? So safety becomes really relevant in that way, and that we need to be sure to be mindful of thinking about safety, both in terms of keeping oneself and others safe. Yeah, so absolutely, homicidal thoughts, self-harm, but safety even in terms of, do I have any concerns related to shelter, right? I mean, if we're talking a disaster where maybe a person's home, or other place, or residence, or place where they would typically stay is no longer available to them. If I haven't had stable shelter since the trauma or disaster happened, right, that's going to be relevant when it comes down to just thinking about how do I stay safe. If we're thinking about a trauma that involves crime, right, particularly where there was an identifiable perpetrator who was responsible for committing a particular crime, you might have concerns if that person was never arrested or apprehended, right? Or there might be concerns about retaliation from the perpetrator's family if the perpetrator was arrested. So there can be a lot of ongoing concerns about safety that folks have that can really compromise our ability to naturally recover after a trauma, depending on a whole range of circumstances. So we want to think about, and so living conditions, yes, somebody said that's living conditions on here, absolutely. And that kind of transitions, I think, to some other stressors and concerns that we need to be thoughtful about. Basic necessities, right? Do I have access to food, clothing, transportation to and from different appointments, right? If I'm going to refer people to other agencies where I think that they're going to be able to get some good help and support for some of the things that come out in the process of me asking these questions, do they actually have a way to get there, right? Those are going to be important things that we have to make sure we ask about and address. Substance use and abuse, right? Again, the toll of these kinds of experiences can be so overwhelming that it's not uncommon that many people may start to drink more, right? Or if you use certain kinds of drugs, you might find that you're using drugs more frequently to try to help cope with and manage reactions that you might be having, right? So there's a whole range of reasons that we want to ask about substance use and abuse, or if you have concerns about how someone else is doing in terms of coping with substance use and abuse. Role functioning, right? So eventually, sometimes folks will try to get back to some semblance of normalcy after a trauma or disaster happens. We might eventually go back to work. We might eventually, go back to school and try to start taking classes again. How am I doing with those things? How's that process of adjusting back to all those just sort of aspects of daily life going? And so we want to try to ask about that. And then interpersonal life. how am I doing in terms of getting along with family, friends, loved ones, coworkers, peers at school, right? Teachers, how am I doing getting along with other folks in my life? And how has that been directly impacted or affected by a trauma or disaster? So these are sort of the core areas that if you take a look at the manual, it's going to guide you through asking folks about when you think about, trying to figure out where you go with some of this. And for those of you who were at the psychological first aid training, a lot of this is going to sound really, really familiar, right? But there's good reason that we go back and ask about some of this again, even in the context of, doing a new intervention like skills for psychological recovery. Because one of the things that we sort of mentioned during that training that I think is important for us to mention now is that, we may ask folks in the context of crisis interventions questions about all of these different areas, but things change and can change rapidly in the immediate aftermath of a trauma. So things can change very quickly from day to day or even week to week during those first month, first couple of months or 3 months or so after a trauma happens. So reassessment can be really, really important, and I think is often very strongly recommended when we're doing any kind of primary or secondary intervention like PFA or SPR. But there are still some differences here. So if we go to the next slide, again, for those of you who are at the PFA training, some of these areas are a little bit different, right? Assessment does look a little bit different. So, there's overlap in the sense that these first 5 areas are things that we often ask folks about when we're doing the information gathering module in psychological first aid. But with SPR, we ask about a couple of specific areas that we don't really ask about in the context of crisis intervention, right? Like PFA. With SPR, we ask about role functioning, how am I doing going back to work, school, or other kinds of things? And how am I doing in terms of my relationships with other people? So interpersonal life. These are kind of new, and these are new things that we sort of now start to ask about in secondary interventions like SPR. Now, why do you think that role functioning and interpersonal life are assessed here, but not in the context of, an acute intervention like psychological first aid? Especially for those of you that were at the PFA training, or maybe have had some background in PFA. Why do you think we now assess for role functioning and interpersonal functioning a few weeks or months out after a trauma or disaster, but don't in the first 24 to 72 hours or so? Yeah, so somebody here said, yeah, delayed reactions, hierarchy of needs is, an immediate concern. Absolutely, I think that's exactly right. Because often when we're thinking the first 24 to 72 hours, there's going to be a lot of disruption in role functioning. Absolutely, right? That's to be expected. There's interpersonal life is certainly going to have some direct impact there, but at that point, it's much more important to create conditions for immediate stabilization. Here, by the time we're doing something like SPR, people will probably have a little bit of time to get back into these areas to try to feel things out a bit, right? To sort of see where they're experiencing difficulties. And so now it becomes all the more important to, I think, assess for and look at those areas. So I'm also being mindful of time. I want to make sure to give folks a little bit of a break so we can, all stand up and stretch before we get into the really fun parts of the second hour here, where we're going to be doing a lot of practicing some of this. But let's skip ahead to the next slide. Let's go ahead and go to the next slide and think about the next piece, which is extremely important here, right? When thinking about this module, prioritizing assistance. We're asking people a lot of questions about ways that their life has been affected since the trauma or the disaster happened. So once people answer all these questions and we have this picture, where do we go with it, right? And what do we do with all this information? Well, first, you've got to try to prioritize what thing you want to address first. And that's going to be a really important piece of this first sort of module here that you're going to do with all survivors. So you just kind of do that by summarizing your understanding of needs and concerns, right? So, a lot of us, especially from, with mental health backgrounds, behavioral health backgrounds, are familiar with kind of, summarizing what people tell us, rephrasing some of the basic attending skills that, folks like Carl Rogers and others have sort of talked about that that I think sort of span all of our work, regardless of what we're doing or, you know, our theoretical backgrounds or orientations. But we just need to let folks know that we attend and that we hear them. Summarize what they've told you so that folks feel heard, right? And know that you've heard the key things they want to tell you. And then also just, you know, ask, right? Ask the person what's the most important concern for them to address. But that being said, more often than not, folks are probably going to have multiple concerns and may not know which one is the most important one to address. So next slide, let's just go through a few questions that you can kind of use to try to help guide that conversation in a collaborative way if folks really don't know where to start, right? You can consider asking people several different questions, I think, to kind of help identify priority areas. You know, so one, is there one of these areas that's bothering you the most? If people endorse, you know, concerns across several of those different areas that we just talked about, which one's bothering you the most? Or is there one problem that seems to be getting worse? Is there, you know, is one of these just kind of gradually getting worse over time? You know, I think can be an important way to help frame that. Or you might even, you know, really consider asking, is there one problem that if we addressed it first, might help with some of these other areas, right? Is there one that we can pick that's going to have a lot of downstream effect on some of the other areas and problems that we've identified here too?